No?
Yeah.
Yeah? Okay. All right, so I'm going to talk about the guidelines for CBS, and part of this is because I was in charge of that guideline group. For those of you with cobalamin C, the remethylation effects, or MTHFR, why don't we talk about those guidelines over lunch? Martina Humler was in the charge of that group, and I've had a lot of interaction with Martina over the years. So I really have nothing to disclose. So if you've ever been to research stocks, we all talk about disclosures, okay? And I just want everybody to know that I'm the PI at Children's National E-HOD database. The reason I put that in is there's some data that I have access to that people don't typically have access to. And so I'm able to talk a little bit about that data. And we'll talk a tiny bit about that in this particular talk. Now, I want you to stop me when I start saying things that don't make sense to you, okay? I want this a little interactive. And although I have slides, if I start saying something, you're like, wait, where did that come from? I can probably tell you where some of that came from. So how many of you guys have ever sat on a committee of any type? About how many of you sat on a committee? And how many of you guys, everybody in the committee agreed? Nobody, okay? So I'm going to talk about the guidelines as published from a committee from the European the European Registry and Network for Homocystinuria and Related Disorders that focused on cystathionine beta-synthase. You can imagine that the goal of this committee was to find the best clinical practices. And the basis of that was to look at the data. We started out with over 1,000 publications. We whittled that down to between 700 and 800 publications. And people on the committee, so at some point it'll flash who was on that committee. We all read all of those publications. Now, not every one individual read all 700 to 800 publications, but we read all of those publications, graded that literature, and decided how good it was. Do you know what the best paper of all over the identification of homocystinuria all the way to when we actually did the end of the data poll? It's Harvey Mudd's 1985 paper, okay? Now, a lot of things have happened since that particular publication, and we're getting ready to do a revision of that probably in the next year. But just publishing guidelines for diagnostic and management moves the whole community forward. But I want you to remember that these are young diseases. We don't know a lot about them. So this is the dreaded biochemical slide, right? I'm a biochemist. This is the dreaded slide. Like, what gives you the homocystinuria? Well, homocystinuria just means you get homocysteine in your urine. There's 3 major categories of this. There's the classical, which is our cystathionine beta-synthase. We're going to talk about that. Then there's the cobalamin remethylation methylene tetrahydrofolate stuff, right? And that's this blockade at methionine synthase that requires B12 and methylene tetrahydrofolate. So what really happens is homocysteine and methionine go in this circle. And it goes in the circle, and it goes in the circle, and it goes in the circle. And homocysteine gets methylated to become methionine, and methionine gets demethylated to become homocysteine. All right? Homocysteine, you have to get rid of it. It's not exactly a great compound to have around, and we'll talk a little bit about it. And so cystathionine beta-synthase helps get rid of it and gives us cysteine down here. Okay? And cysteine is kind of important because that's an amino acid too. And as we all know, amino acids are the building blocks of protein. And so we need all these amino acids to build protein. Now, methionine is a really important amino acid. It's one of the essential amino acids, which we have to have it in our diet. But it's also the first amino acid in every single protein we build. All right? Cysteine is a really important amino acid. It's one of the sulfur amino acids. It's essential for us to be able to deal with free radicals. And free radicals have been in the news a lot. Those are the things that cause damage all over our cell. Okay? So when we were talking about inflammation, So free radicals and inflammation are similar, not exactly the same, but similar. And so we need to make all of these things to be successful. And if you have a block in any part of this, your homocysteine goes up. And depending where the block is, it impacts the other amino acids. So let's talk about basic biochemistry. And the reason we're doing this is because I think it's important when you think about management to think about this very basic thing. And these are things that many of you guys saw in high school, right? A typical reaction is like a river. It flows, right? And A plus B becomes C. Now, a biochemical disorder, any biochemical disorder, is like putting a dam in that river, right? We're going to flood upstream, and we're going to be deficient downstream. So when you think about therapies for metabolic disorders, we want to suck up the flood or prevent the flood to begin with, and we want to replace what's downstream so that we fill the downstream stuff, all right? And if we think of it simply like that, you can start saying, oh, I'm on this medicine because of this. I'm on this diet because of this, okay? And it helps you think about what are the things I'm taking and why am I taking them? So I'm either sucking up the floodwaters or preventing it to begin with, or I'm replacing downstream. So let's talk a little bit about CBS deficiency. Well, we had a great introduction about CBS deficiency. Well, so Harvey Mudd, as I said, was probably the best summary we had ever seen. What I was telling Margie during the talk is how many of you guys realize that all those charts were hanging out in his widow's house? So all those questionnaires, all the charts, they actually were stored, and another paper actually came out more recently, but somebody had to go through all those records. All right, let's talk a little bit about CBS deficiency. So I think about 4 major categories of things that we have problems with. Our CNS, that's our brain, basically, okay? Now there's intellectual disabilities. There are the psychiatric disease that we see, and in some cases, people have movement disorders, okay? We've gotten a much better job of taking care of people younger and identifying younger, right? So we're seeing a little less intellectual disability and a little less movement disorders, but we're not as good at some of the others. And part of that is because those things haven't made it into the literature. So the psychosis, there's actually 3 case reports about psychosis in the literature when we did the literature poll. There's a few more now. Mental health, well, if you looked at the literature, mental health problems, depression, anxiety, ADHD, they're mentioned, but they're never quantitated. So we didn't know what percentage of individuals actually had this, but we knew sitting in a room full of experts, anxiety and ADHD were really common. Because we said, I've got all these patients, they have these things. Eyes, ectopic lenses, that's the dislocation of the lens, and severe myopia. This was actually how historically people would present. They showed up at the ophthalmologist because people didn't understand what the other things looked like. Now we see a lot less ectopia lenses now. Part of that is therapy. Skeleton, this is the overgrowth of the long bones. So we usually think of this being somebody excessive height, long limbs. We know osteoporosis is common, but again, numbers weren't very good. And then some bone deformities that we can see on x-ray. Interestingly, therapies actually have taken the description of excessive height and long limbs away. So if you start intervention very early, you're less likely to see it. And then the vascular system. I think this in some ways, as a doctor, is the thing that makes me most nervous. It makes my patients less nervous. And that's the clots. We see a lot more venous clots versus arterial clots. A lot of the pieces of literature we actually threw out, because remember I talked about there were about 1,000, and we threw out about 200 papers. A lot of that had to do with a description of hyperhomocystinemia, and that was described in the vascular literature with individuals who were having slightly elevated homocysteines prior to the myocardial infarctions or heart attacks. And homocysteine is actually acute phase reactant. It goes up under body stress. And we don't know how much higher it goes in somebody with homocystinuria than a typical person, but we do know that it increases. So, okay, homocystinuria, CBS. The original descriptions were you had not B6 responsive and B6 responsive, or pyridoxine. So people who were B6 responsive, pyridoxine, you gave them B6 and they got better. And they did great. And these were typically individuals who would present at older ages because their symptoms weren't bad. And then you have the not B6 responders, and you give them B6 and they don't respond. And when we start talking about CBS guidelines, we have divided those two groups artificially. There is very clearly a group of individuals who are partial B6 responders. And we've discovered that on several of the databases. In individuals who will have a partial response to B6, it will not be a complete response. And it took a little while to describe this. So a full B6 responder is I give them 250 milligrams of B6, and a homocysteine of 300 becomes 10. Okay? A partial responder is someone who I give them B6 and it drops some. Okay? A non-responder is I throw them B6 and their average total homocysteine doesn't move before. The reason it's important to keep these separated is B6 responsive respond to B6, and actually the guidelines have a different goal total homocysteine. It's less than 50 micromoles. They often don't need metabolic foods. They may or may not have betaine to get them to the place. A not B6er does not respond to B6. The total goal homocysteine is less than 100, and I'll explain why that number exists. Metabolic foods are often needed, and betaine is often needed. Okay, the partials have to live between. And they're actually they're a complicated group of folks to deal with. So let me tell you about, this is a newborn screen case. This is a 15-day-old with positive newborn screen for elevated methionine. As many of you know, our newborn screens look at methionine as the marker for total homocysteine. I am sure Margie and Danae can talk about how it's not the best marker because we'd rather look at homocysteine. This individual had no liver disease. Why is that really important? Because children with liver disease will have high methionines because their liver can't process the methionine. It's a full-term infant. And the newborn screen, all we got reported on this newborn screen is greater than 150 micromole per liter, which within this particular state, I work in DC, I deal with 6 states. Within this state, this is an abnormal result. When we saw them, their total homocysteine was 137 micromoles per liter, with normal at the lab was less than 12 micromoles per liter. Their methionine was 376 micromoles, and their free homocysteine was 9. This child has CBS deficiency, and we go on to show some mutations. So the next thing we're going to say is, okay, do they respond to pyridoxine? Because clearly if they respond to pyridoxine, what I'm doing as a therapy is very different, right? And so there's actually recommendations of how to check if somebody's pyridoxine responsive. You determine it by using 10 milligrams per kilo per day up to 500 milligrams of pyridoxine off all multivitamins, all pyridoxine-rich foods, which honestly in a neonate is not too complicated, for up to 6 weeks. That's a really long time. I'll tell you, if you're B6 responsive, I'm gonna know really, really fast. If you're a partial, that's where it gets complicated. And different docs have different times when they're like, I'm bailing, this is not gonna be responsive, we're gonna start this diet. You gotta check the total homocysteine 2 times before you start the pyridoxine and 2 times afterwards. A response is equal to a total homocysteine less than 50. And if there's a decrease of 20% and you're still greater than 50, there is utility to continue the pyridoxine. What that means is if you don't respond with a change of greater than 20%, or yes, greater than 20%, you don't necessarily have to be on the pyridoxine. Most practitioners will actually leave you there. So this child was non-responsive. Let's take another story. So this is an older individual. This is a 22-year-old woman who walked into our clinic. She actually had a new internist who said, You're really tall, you dislocated your lenses, maybe you have CBS, I should probably send you to the metabolist. She dislocated her optic lenses at 8 years the first time. She's tall statured. This is a woman who's over 6 foot tall. Her family history is such that she should not be that tall, all right? Now, to put this in perspective, height is based upon your parents, right? So if you have tall parents, you should be tall. If you have short parents, you should not be tall. Now, I've had folks from Guatemala. You guys know Guatemalans, they have a tendency on average to be short, where I had a mother who was 4'8" and a father who was 5'1", and their child was 5'7". Okay? Now, this child ends up having CBS deficiency. He was disproportionately tall, even though if you put him on a growth curve, he would have been on the shorter side of normal, right? So this person was inappropriately tall for her family. She had a pectus. Her deep vein thrombosis occurred when she was 14, and she had just had a pulmonary embolism at 22. She had normal development. She's a college graduate. She always did well, always got A's and B's. She was on a multivitamin and warfarin because of the PE and the deep vein thrombosis. She was adopted, so we don't really have any family history. Her total homocysteine was 150 micromoles per liter, and the repeat was 120. These are both elevated numbers if normal is less than 12. And her methionine was in the high normal range. Wasn't particularly striking. We gave her pyridoxine, and she came down less than 50. And in fact, when we got the sequencing done, she's a pyridoxine responsive. All we had to treat her with was pyridoxine. She actually normalized she normalized at 150 milligrams of pyridoxine, her total homocysteine. Now, people are like, why did she get missed? Well, remember those multivitamins she was on? We had to take her off them. She got missed because she was on a multivitamin. And people said, oh, your total homocysteine is 50. You can't have homocystinuria. You're going to have Marfan syndrome. Does this sound familiar to some people? Yeah. All right. So what are the goals of therapy? Well, the first thing I have to figure out where you are. Are you a pyridoxine? Are you a non-pyridoxine? Are you a partial? And how do we do that? And how do we figure out what I need to do? So first of all, what are the goals for laboratory? What are the goals for diet? And what do we do to keep you all sane? And I mean that in terms of treatments. So if I make your program too complicated, or if you're unable to follow the diet, then that's not useful. If you cannot do what we ask you to do for whatever reason, that is not keeping you sane, okay? It's got to be practical and it's got to be real. And that brings us to the guidelines. So this is the ultimate kind of thing in the guidelines. Again, though, this is a compromise. So if you look at a number of these names, you may recognize that there's some names from many different places. We've got folks from throughout Europe. We have folks from, I'm going to say Great Britain because they may not be in Europe very long. We've got folks from Qatar. Now, Qatar has a very, very high rate of homocystinuria, which is why those folks. One of the issues that we ran into is if you're going to make recommendations for therapies and for laboratory, everybody has to be able to do it, okay? So this is not laboratory I can do in a research setting. This is laboratory that I have to be able to do everywhere. This has to be diet I have to do across all of these countries, locations, insurance pathways, and this has to be basically guidelines that can be used by people throughout the world. And I think that's really important because I think, and these guidelines have to be based on as much lab or as much literature as we possibly can gather. And as I said, greater than 800 papers. So, okay, this is the question. What is your goal of total homocysteine level for a classical? This is not a B6. I actually said it earlier. Does anyone know what the goal is? So normal is less than 12. This is total homocysteine. B, did I hit B here? E, elephant? Yes. So the recommendations are less than 100. Where did that come from? That seems really high. Well, so that actually, and some experts think it should be 70 to 80. So where did that come from? And this is actually the guideline. It's statement number 15. There are many statements. So let's talk about homocysteine, homocysteine, and total homocysteine. And this is from Dr. Viktor Korfich out of Prague. And I think this is a perfect example. So when you sit down and have a conversation with your doctor, we talk about homocysteine. There are actually several types of homocysteine, and they all sound the same. So you have homocysteine, which is the yellow is the sulfur, and then the carbons are in the gray. Your homocysteine, which is a dimer. You have protein-bound homocysteine, so this is protein with homocysteine attached. And then you have total homocysteine, which is typically what we're measuring, and that is all of these things combined. So the guidelines are based on total homocysteine. And the reason is because people throughout the world can measure it. Homocysteine, that dimer, is what almost all the research studies have been done. That is extremely hard to measure accurately outside of research study. It has to be drawn immediately, spun within 30 seconds, placed directly on ice. Now, how many of your clinics can do that? My clinic can't do that. So that's why we're going to talk about these guidelines. So what we first had to figure out is what's the relationship to total homocysteine versus free homocysteine? Because remember, the research is done on free homocysteine. We're measuring total homocysteine. And this actually is in our publication, and this becomes the basis of this. And we're going to move on to say why this is really important. But this is individuals who had free homocysteine and homocysteine measured at the same time. Okay? So that's why it's in here. I know it's confusing, but it's because I have to explain. So we're going to talk a little bit here a second how to determine the goals and how we get there, right? So the reason that number was selected, and I'll tell you that again, is because there was a beautiful study done in Ireland when they started newborn screening and looked at control. If you're able to keep your free homocysteine less than 11 micromolar, you have normal intellect, normal growth, normal eyes in the first 4 years of life. They did not expand that study up past the first 4 years of life. So the reason it's 100 micromolars total homocysteine is because of that study. That was the only evidence to set up those numbers. Okay? So that is the data that tells us where to go. Some people say, well, isn't lower better? Well, it might be, but we don't have data. And remember that sanity component, right? How hard, as was illustrated in the natural history study, is it to keep our homocysteines down? And these are people who are in maximum therapy, right? It's really hard. So how do we do that? Okay, diets and medications. So this is my illustration of that pathway that we looked at, okay? So think of what we do with our methionine as a black box, okay? We eat a diet and we put it into that black box. And our homocysteine goes up if we can't get out of that black box, okay? So if we have a block in Cystathionine synthase, our homocysteine goes up. We don't make cystathionine. And so the more methionine you put in that box, the less it can escape except as methionine. Okay? And that's classical CBS deficiency. So that's the reason why we do the diet. Okay? Is that we're feeding methionine into that box and it can't escape. And so that's why you'll see a higher homocysteine and a higher methionine together, is because there's so much methionine that goes into that box. The thing we can control is our diet. The thing we cannot control are things like, I have a cold, I'm releasing methionine from my muscles, right? I have an illness, I have a fever. We can try to prevent those things, but those are not things we can control. I have a patient that has rheumatoid arthritis. I can treat his rheumatoid arthritis, but he has to have a flare. And just because he has rheumatoid arthritis, his inflammation is up. So I actually know when his rheumatoid arthritis is flaring because I can see it in his homocysteine, right? My control is his diet, or his control is his diet. Our rheumatologist's control is his rheumatoid arthritis. So how much sulfur amino acids do we eat? So this is taken again from Victor. And what this is looking at how much sulfur amino acids we eat. So it's really hard to measure things. But methionine is a sulfur amino acid, cysteine is a sulfur amino acid, homocysteine. And I'd like you to compare the amount of homocysteine that we eat if you're or the amount of sulfur you eat if you, and this is milligram per kilo per day, if you're a meat eater versus a vegan, versus a vegetarian, okay? Those numbers are actually surprisingly big. And I really want to focus on how much methionine you eat in meat eaters versus vegans. And you can see that vegans eat, on average, half the amount of methionine than a meat eater does, okay? And that's because that's part of the reason why we do this diet restriction. You also might notice that cysteine is not as impacted as much as methionine is. And so I think this is kind of interesting because that gives you a basis of why we try to avoid meat-based products. We do those kinds of things is because there's this double in your diet. And if there's things you can control, your diet is one of those things. So there are, in fact, recommended daily intake of methionine and cysteine that we're supposed to have. In general, the WHO and the US recommendations are about the same. This is milligram per kilo per body weight. For those of you who count methionine this is methionine. For those of you who count methionine, this is the basis of what your dietitian is actually. And you need to have methionine and you need to have cysteine in your diet because you need both of those. Because remember, methionine is really important to start every protein, and cysteine is important, if nothing else, for your glutathione production to help suck up extra free radicals. And children 3 years and older have a slightly higher than adults. Infants can be about 150% higher in the first year of life. All right? Diets and medications. Okay, so that's the methionine story. Let's talk about medications. So most of our medications, the goal is to take our homocysteine to methionine. That's what the goal of that is. Now remember, this is a circle, right? So you can get yourself in a dirty circle if your methionine is too high because your homocysteine is going to get converted to your methionine. But this is the whole goal. So pyridoxine helps us use cystathionine Beta-Synthase better. But betaine is that conversion of homocysteine to methionine. And the package insert is, and the recommendations are what's in the package insert. And the reason these are the recommendations is because this is what was studied. 6 grams per day for adults and then 250 milligrams per kilo per day for children. Most folks are on more than that. That betaine doesn't work if you're not folate and B12 replete. And so a lot of people are on folate and B12 supplementations, in part because you're not getting B12 from meat because you're not eating meat, and in part because B12 and folate travel together. So you need to be replete. And that's part of the things that we look for. So we look for B12 levels, we look for folate levels. That's to make sure you're replete, because none of this works well if you're not replete, which means you have enough. All right. We're going to talk a little bit about kind of outcomes here. So brain. So brain is one of the things that scares families. So the total homocysteine level was based on a single study out of Ireland in a fairly large cohort that looked at 4 years of life outcomes in terms of intellect. And what it demonstrated is individuals whose Free homocysteine was 11 micromoles or better, had normal intellect in the first 4 years of life, which means we have to diagnose people early. We can't be diagnosing people later, and that's one of the big important things about newborn screening. Psychiatry, anxiety, depression, psychosis. The answer is yes. Some recent studies say that it might be related to early control, but that is not necessarily clear. And that's because it's not a clean division between people who have extremely good early control will have less anxiety or depression as an older individual. It's not that clean, but it looks like it might. Clearly, better control decreases your risk for psychosis. Okay, thrombosis. Prevention is the best policy, and so spontaneous thrombosis occurs at 120 total homocysteine of 120 micromoles or higher, which is part of the reason why when we look at those numbers and we worry about thrombotic events and you're 150, I get anxious because you're likely to clot. If you're 300, I get anxious. Now, what we don't have data for to say, if you're 300, you're at X amount percentage higher risk for thrombosis than if you're at 150, than if you're at 100. But we do know you don't typically see spontaneous clots less than 120 unless you have other risk factors. If you have a thrombosis, the recommendation is to use the usual interventions. This is aspirin, this is heparin, this is Lovenox, this is all of the normal stuff. The big discussion is if you've had two, do you do continuous warfarin or Coumadin? That is the recommendation from the American Heart Association for anyone who has 2 or more thromboses. Okay? We had a big fight about this. I'll be honest, the room had a big fight about this. Because the question is, if you control the homocysteine, does that take away the thrombosis risk in somebody who had elevated homocysteines at the time of their thrombosis? And again, the data isn't very clear about what to do, so we just kind of follow what our local recommendations are. Special. So remember thrombosis, you really kind of want to avoid it. So there's 2 big special categories. There's lots of special categories, but 2 big special categories. Surgery. So let's say you have a known planned surgery. You're getting your tonsils out, you need your wisdom teeth out, you have to get your appendix out maybe, you're having a surgery. So first of all, you need to avoid dehydration, you need to avoid catabolism. Catabolism is a really fancy metabolic word that means we need you not to break down the muscles that you have because we need you to make sure you get enough calories to prevent your muscles from thinking they're starving. Okay? It's best if it's planned. There is nothing worse than getting called from a dental office and saying, I've got your patient with, what do we do with them? They just handed me this letter. And it's best if the therapy is maximized, your homocysteine as low as we can. If you're having something in which you know, like a joint replacement, the usual antithrombotic interventions. So in individuals who have a surgery in which they're unable to get up right away, all those things, you're going to use high-risk antithrombotic protocols. There's a number of them that are used for different situations. The other special, would you call it special, Danae? The other situation would be pregnancy. Now, again, there's little data. And the experts had lots and lots of disagreements about this in terms of when to start. So everybody said, well, let's start early. What do you think early means? So we all agreed we needed you on antithrombotic interventions by the 3rd trimester. Some folks said as soon as they learn they're pregnant. Other people are like, nah, how about mid-2nd trimester? I think you would say shots aren't much fun.
No.
Shots aren't much fun. And we all agreed that you had to go at least 6 weeks postpartum. People are like, why do you need to go 6 weeks postpartum? It's because it takes that long for your uterus to involute, and so you're releasing a lot of protein as your uterus is involuting. So the biggest risk for clotting is when you're most biochemically active, and that is like right before delivery and then the postpartum period, which is why going at least 6 weeks postpartum is the recommendation. So there was a little bit of concern, in part because of MUD studies, in part because of some of the other studies about outcomes. Were individuals with homocystinuria more at risk to have poor outcomes from pregnancy? So we know that homocystinuria, unlike PKU, does not have a risk in terms to the fetus in any other way other than thrombosis risk, okay? If you actually read those studies, there's a number of individuals, number 3, that actually drove the data the way it drove, and those folks had multiple miscarriages. They were also uncontrolled in terms of their homocysteine, okay? So if you have good homocysteine control, you have good outcomes. All right, at this point, I'm totally open to questions, and I'm sort of in the way for lunch. You can corner me, you can email me, you can call me, all which.
So there's definitely time for questions.
Okay. So let's hear your questions.
At what age do you recommend a child with HCU get a DEXA scan?
So the question is, what age do we start looking at bone density? So there are not good norms for children. NIH actually published good norms for children, or published some norms for children. So I actually start doing my DEXA scans between 5 and 10. The natural history study is looking at DEXAs every year. We generally felt even in the adult population, we should not look at DEXAs more frequently than every 3 years. And the reason is because in the adult elderly population, you really can't see a significant DEXA change in greater than 3 years. But that is in individuals who are, we're looking at older than 50. We don't know whether kids younger will have big changes that we were able to see. I know one of the questions over here was, what is the intervention? There is no data in homocystinuria in terms of any of the current available interventions beyond making sure people are calcium and vitamin D replete. As you all know, none of us are vitamin D replete because we don't see the sunshine enough, and we put a bunch of sunscreen on our children so they don't see it. So one of the things that we can do is we can check 25 hydroxy vitamin D. And the reason I'm being very specific about that is a lot of labs or a lot of places will look at 125, and that's how much gets converted. That's not how much you're getting in your diet. Calcium is much harder to look at because our blood really likes calcium and keeps it in a really similar range no matter what our bones think about it. So that would be the kind of DEXA stuff. The problem is norms. You know, if you don't have good childhood norms, it's hard to say. For osteoporosis is considered a Z-score based on age and gender less than 2. So a -2 and less, so that's -2, -3, -4, -5, is considered osteoporotic. Osteopenia, depending on the definition, is usually a Z-score of less than -1 to -2. And if you've got the right norms. Now, if you're comparing a child to a 60-year-old female, that's not a good comparison. Okay, so the one thing you all can do is make sure you're vitamin D replete.
Wouldn't you say that if the formula plays, like, a diet adherence plays a big role into bone density, though, because the formula has all the nutrients?
Should have all the nutrients, yeah. So what's the role of formula here? I didn't talk anything about formula, and there's actually a reason why. There's places in Europe that don't actually have access to the formula. So the formula does something great. The reason it smells so bad is because it gives you free cysteine. All right, that's why it smells so bad, that free sulfur in it. So you're repleting your sulfur, but you also get all the extra vitamins. And what it's really good at is giving you all the other amino acids, but not methionine, not homocysteine, extra cysteine. But the reason it smells so bad is the cysteine in it in most cases, because anytime you see a free sulfur, it smells like rotten eggs. That's what your formula smells like, right? That's the free cysteine. One of the discussions we actually had is whether people should take cysteine replacements. Again, it wasn't available everywhere. There wasn't good data. So we couldn't make a comment about that.
I just had a question in regards to the treatment for osteoporosis.
Mm-hmm.
Have any of the treatments for the older individual that are available, would they compromise anything that a homocystinuria patient might be doing?
So not to our knowledge, but again, it's not been well treated. The one thing you have to pay attention to that I forgot to put in here is nitric oxide used in surgeries, like laughing gas, makes homocysteine go up in everybody. Okay? But not to our knowledge currently in the current therapies do we know, so some of the bone density stuff that we see on TV. It's not been adequately studied in individuals with homocystinuria. I have a few adults that are on it. I haven't observed a difference, but that doesn't mean that if you looked at a big population of individuals, whether or not that's just my few adults or whether that's the population. Okay, Danae, or no, Margie.
Since we have one cobalamin C family here.
I was gonna eat lunch with them.
Oh, okay.
I'm gonna eat lunch with the cobalamin C. Where are you guys? Okay, we're gonna talk because diet is different in cobalamin C. Okay, so we'll eat lunch. We'll talk about the differences. So cobalamin C and methylene tetrahydrofolate reductase, or severe MTHFR. Say it fast a few times. The recommendations are different. They're very different for diet. They are different with drugs, and they have a slightly different phenotype, so the way that the patients look, which sometimes makes it confusing to do it here. All right, other questions for me? Because I stand in the way. Yeah.
You said something earlier about cysteine and glutathione, and I missed it.
So cysteine is you have to have cysteine to make glutathione. So glutathione is a compound which is made by glutamate, cysteine, and it will come to me. But you need to have it to make glutathione. It's glutathione is a product. Okay, other questions? And if you're going to ask me about glutathione replacement stuff, is that the follow-up? No? Okay. Because I can answer that. Usually if you take things that say they have glutathione in them, they get broken down by the stomach and it's not actually what you think it is.
Yeah, I think actually his are high.
Mm-hmm.
So is that a problem?
So it matters if it's oxidized or reduced. Okay, other? Way in the back.
In case we had to do a surgery, how would we prepare for that?
Oh, how do you prepare for surgery? So I'll tell you what we do with folks in my clinic. I actually, if I know in advance, okay, so we're going to talk about it in advance and emergently. So if I know somebody's going to have a surgery in advance, I have provided them a surgical letter that has a protocol which should be followed by the anesthesiologist. If they're having their surgery in-house or they're having it in our institution, I usually have spoken to the anesthesiologist We have a POC clinic, which is a pre-operational clinic for complicated patients. They almost always, I will send them through POC if I can, so we have a post-surgical plan as well, which includes antithrombosis kinds of things. So their pre-surgical plan is I want them to fast for as short a period of time as I possibly can, agreeing with the anesthesiologist, so we may bring somebody in overnight if I need them to fast for 12 hours. We may be doing fluids overnight with calories. I want an IV started with D10 normal saline in most cases, and 1.5 maintenance to provide calories throughout the surgery as opposed to normal saline and lactate. I need them to eat if they're planning on going home or drink and be able to keep it down in post-op, and then we will stop the dextrose containing fluids. If they have to get admitted overnight, or if they have to get admitted to be watched, which is usually what happens in most cases because kids don't like to eat after they have things like tonsils out, we will have a set-up antithrombotic regimen post-op with fluids. If it's something like a joint replacement or something like that, they certainly get antithrombotic therapy throughout their recovery time, which is equivalent. They're considered a high-risk thrombotic, and that's the language that I use. If it's an emergency, right? You're going to have to sedate somebody because they broke their arm, because they were falling off the jungle gym at school, and they need to have it set in the OR with pins and plates. And yes, this happens because we all know what kids do. And they show up in the ER. What happens is the families are instructed to call us immediately. There's always a doc on call, and we'll give a fluid plan. It's very similar to what I just gave. But it ends up being a little more complicated because we have to get people to get the right stuff. So D10 normal saline, D5 normal saline. D is dextrose. Dextrose is basically glucose. D10 is 10% dextrose. D5 is 5% dextrose. Is a method to give calories to prevent your muscles from breaking down. D10 normal saline doesn't exist in most hospitals. They have to make it, which is why having it in advance kind of helps. I can talk someone through how to make a bag of D10 normal saline on the phone if they don't have it easily. You do not want to be sitting around for pharmacy to put it together. You want it to be able to be done fairly emergently. But an emergency procedure takes a little bit more scramble. Other than nitric oxide, I don't usually restrict any of the other anesthetics because there's no evidence that they increase somebody's risk for thrombosis. The risk for thrombosis in an emergency case is significantly higher than a planned surgery, in part because of all the other things that go along with a trauma or major illness. Did that help? I mean, that was a lot of stuff. Yeah, so call your doctor. All right, I think it's lunchtime.